beforehand. I'm really sick of talking about it, and I really want to start doing stuff. So I welcome your input, and I welcome you helping me in this endeavor, inviting me to work with you, if you want to work with me, and I'll go over what that means as we go on. But it's clear that there are high rates of liver cancer in African communities around the U.S. I didn't see a lot of information about that, so I really went looking for information, and I found information about the high incidence of liver cancer in Africa. And that's what I'm going to focus most of my talk on, but it really relates to the communities here in the US. Okay, let's see. I'm trying, it moved, okay. So I have to give acknowledgments. A lot of my colleagues are on this list. I went to a seminar put on by the Hepatitis B Foundation last year in April and took a little bit from all of these individuals, their presentations. But the person I really want to commend the most is the person at the bottom from Cairo University, Dr. Ashraf Omar. And I went online and I found his presentation from the Conference on Liver Disease in Africa from earlier this year. And I have to tell you, it was a wonderful presentation, very enlightening, but unfortunately very sad as well. And we'll talk about that in the next 20 or 30 minutes. This is my agenda. I'm going to talk about epidemiology, incidence, the guidelines for screening, which I do not agree with, risk factors, challenges, treatment, unmet needs, and future directions. So let's talk a little bit about hepatocellular carcinoma, hepatoma, or HCC. It is the third leading cause of death from cancer worldwide, fifth most common in men, seventh in women. As opposed to most cancers where mortality rates are decreasing, both the incidence and death rates are rising from this deadly disease. Worldwide, it's primarily due to hepatitis B and hepatitis C. In the US, it's mostly hepatitis C and non-alcoholic steatohepatitis, or NASH. Globally, there are 600,000 deaths annually, which means that in the hour that we're going to spend talking today, going over this topic, 70 people around the world will die of liver cancer. The overwhelming majority of these cases occur in people who live in or are from sub-Saharan Africa, Southeast Asia, and the Eastern Mediterranean areas of the world. And this last bullet, this last sentence is good and bad. So recent therapeutic advances and continually updated expert guidelines have improved the prognosis of HCC from a death sentence to a cancer that can be detected and treated at early stage for good outcomes. When I first started in medical school back in the 80s, the 6-month survival for liver cancer was about 5%, which is absolutely awful. Now, if you find a cancer early, the 5-year survival is 70 to 80%. But that's the problem. We are not finding these cancers early. The overwhelming majority of people in this world who need to be screened for liver cancer are not being screened. They're presenting at a late stage, and there's not much you can do for that. That happens in the US, it happens in Europe. I think it happens to a greater degree in other parts of the world, and especially in Africa, which we'll talk about, like I said, in a few minutes. Now, the next couple of slides are going to be talking mostly about Africa. The second highest incidence in the world is in Africa, which is 8.8%, which is only surpassed in Asia. And actually, Mongolia has the highest rate of liver cancer. North Africa has the highest rate in Africa, primarily due to the hepatitis C rates in Egypt. The sub-Saharan Africa region also has high rates, but it's highest in Western Africa, followed by Eastern, Middle, and then Southern. When you look at countries around the world, The incidence of hepatocellular carcinoma is very high. If you look at the 15 most common, the countries with the most HCC, 6 out of the 15 are from Africa. Egypt is ranked number 2 in the world with 28,000 cases a year. Guinea, the Gambia, and Ghana are also in the top 10. Sub-Saharan Africa in 2020 had 38,000 cases of HCC. And in this area of the world, it's the second leading cause of death in males and fourth in women. And it also occurs in a younger age group with a median survival of 3 to 4 months. So just very sad to hear that. Very sad. These are the screening guidelines from 2018. And you can see here on the left, we talk about different groups and different ways, times to screen them. So for Asian males who have hepatitis B, you only start screening after the age of 40. For females from Asia, it's over 50. Anyone with hepatitis B with a family history of liver cancer, you screen no matter what age they are. If they're from Africa or from North African Blacks with hepatitis B, you start screening the second you meet them. And then you could see the rest are cirrhotic patients that you screen no matter what their age is. You can see at the bottom of the surveillance benefit uncertain, hepatitis B carriers younger than 40 if they're males and 50 if they're females. Now, even though this came from my boss, Dr. Marrero. Oops, sorry, let me go back. Sorry about that. Even though this comes from my boss in 2018, published in Hepatology, I don't agree with this. In my experience, I've had multiple patients from Asia develop liver cancer in their late teens, early 20s, early 30s. So in my practice, the second I see somebody who's hepatitis B surface antigen positive, I start screening. I don't care if it's not cost effective. I've been scarred by young people from Asia dying of hepatitis B related liver cancer. None of these deaths should ever occur because if you pick it up early, you can cure these patients. Let me backtrack a second, and I'm going to get to this slide a little bit later, but the hepatitis B vaccine was one of the first vaccines to show it's an anti-cancer vaccine. In one country in Asia, they started vaccinating everybody at birth. And what they showed within 10 to 15 years was that the incidence of teenage HCC decreased significantly. So again, you wouldn't be screening those patients, but there is cancer in young people who have hepatitis B. It is much more common, I'll grant you that, in young people from Africa, but it's still very common. So in my practice, if you have hepatitis B, I screen you from the get-go, no matter what your age, no matter what your background. This is a relatively old slide, but it talks about all the different organizations and the different recommendations. And you can see the AASLD, which is my organization, recommends an ultrasound and an alpha-fetoprotein every 6 months. It used to be questionable whether or not you need an alpha-fetoprotein, but now they recommend doing both. The European Association previously recommended an ultrasound every 6 months. The Asia Pacific Association recommends alpha-fetoprotein ultrasound every 6 months. And you can see it's basically across the board. The National Comprehensive Cancer Network and the VA, I really don't know if this has been updated, but screening every 12 months, in my opinion, is not correct. It needs to be every 6 months. And Japan came out with something years ago talking about high-risk patients getting screened with imaging every 6 months and other testing, blood testing every 6 months. And then extremely high-risk patients get an ultrasound every 3 to 4 months. And then other testing, labs, CT, MRI every 6 to 12 months. It's really unclear what's the best way to screen patients. It is clear that we have a lot of improvement in finding screening tests Because even with accurate screening, we are still finding about a third of patients not curable at the time we find their cancer. And that's something in future directions that we'll talk about. This is what I alluded to before, that hepatitis B vaccination on the left, you could see in young people, the risk of HCC went down in those who were vaccinated. And on the right, treating hepatitis B lowers the risk of HCC. So if you walk away from 1 or 2 points from this lecture, number one should be, we need to find everybody who has hepatitis B. We need to start them on treatment, and that in and of itself will lower the incidence of HCC. This is one of many slides that I could show you, but it is clear that surveillance, which is another word for screening, reduces mortality in patients with chronic hepatitis. And you could see here on the left compared to the group on the right that when you screen patients, you're much more likely to get them at stage 1, which is curative. You can see here almost half the patients had curative therapy versus 7.5% on the right. And you can see the mortality was much higher on the right. So screening is absolutely necessary and is the standard of care around the world. Getting back to Africa, this was a study that looked at over close to 300 studies. The majority of hepatitis that caused cancer was hepatitis B, followed by hepatitis C, and then there was combination with hepatitis B and Delta. It was shown that aflatoxin B1 and dietary iron overload, primarily in beer, are environmental factors. But other things that must be considered are alcohol, fatty liver, HIV, and tobacco. All these things raise the risk that you're going to develop liver cancer. And if anybody has hepatitis B, fatty liver, all these things need to be avoided to lower the risk of cancer. What are urgent challenges in HCC? Well, I think primarily it is eliminating viral hepatitis by 2030, as the World Health Organization has put forward, to raise awareness so that people find out that they have hepatitis B, that they have hepatitis C, that they have fatty liver. And there are many projects underway, which I'm partaking in, where we are trying to go out there and raise awareness, going into the community and asking people to get screened. In the US, it's become easier because it's now recommended that all adults be screened once for hepatitis B and hepatitis C. One of my pet projects is to try and get pharmacies to be willing to set up days of the month where they get screened, where you can offer screening that's paid for by insurance companies. And obviously, for those who don't have insurance, to have others pay for it. I think overall, it will help this country and it will help the world if we can eradicate viral hepatitis by 2030. One of the things that they're trying to do in Africa is improve infection control in blood banks and dialysis centers. I think in the US and in Europe, that's been done. And at the bottom, I put forth my recommendations. I forgot to add fatty liver, but we need to screen for hepatitis B, hepatitis C, fatty liver, screen for liver cancer. And once we have these individuals, we need to treat them. We can cure Hep C, we can control Hep B, and we can cure liver cancer as well. It is not necessarily a death sentence to have liver cancer, especially if you catch it early. I pride myself on catching liver cancer early in my patients. And I've had a couple of patients in the last week or two who have presented with small masses, which may be cancers, may not be cancers, but now that we know about them, it is very likely that if it turns out that it's a cancer, I'm going to be able to cure it and let them lead a normal life. One of the things that we need to do, both here and in Africa, is shift the task away from our healthcare providers, like myself, primary care providers, I have to tell you, I personally am too busy to make sure my patients get their screening for liver cancer. So I'm actually in the process of doing a pilot study where I'm going to hire a personal assistant or a navigator who's going to check up on me and check up on my patients and make sure they all get screened. I'm going to give you an example. I had a patient who has hepatitis B, cirrhosis. A year and 3 months ago, she had a mass in her liver that was concerning for a small cancer. I reached out to her and told her that we need to take care of this. And where did she want to get her MRI? I really didn't go into it with her, but for whatever reason, she ignored me. She didn't get it done. I saw her in the office about 2 or 3 months ago, and to my shock, she had never gotten another MRI. In retrospect, I should have ordered it and just made it happen, but I didn't. The good news is, even though I thought she would be a goner at this point in time, that mass has only grown to 2 centimeters. It is now a cancer. It's documented to be a cancer by imaging criteria, but she's still curable. So, you know, it could have been so much worse. It should have been so much worse, but she was fortunate that it was a slowly growing cancer. I think it's important to find hard to reach populations. In the US, it's going to methadone clinics where people have high rates of hepatitis B and C. I think it behooves us to go into the African communities all over the US and set up a registry and try and make sure that everybody, absolutely everybody in the community gets screened at least once and finds out if they have Hep B, if they're protected against Hep B, because the incidence in the African communities in the US is probably 10 to 15%, which is really extremely high. Work with primary care. One of the things I want to do with my patient navigator is reach out to primary care groups, and both in the Penn system, outside the Penn system, and let us help these communities. Let me help these practices reach out and screen everybody to make sure we can find everybody with Hep B and C. In Africa, only Egypt and Rwanda are on track to eliminate viral hepatitis, and that should be by 2030. I apologize. Egypt is actually doing a fantastic job. I don't know enough about Rwanda to say where they are. I just saw them noted in the lecture that this gentleman gave. But Egypt is doing an amazing job. The amount of hepatitis C in Egypt is about 15 to 20% of the population, and it looks like they have screened close to 90% of their population for hepatitis C. Now let's talk about the treatment of HCC and the unmet needs. One of the problems alluded to was the lack of guidelines in Africa. I personally don't think that's a major problem because we have guidelines all over the world that they can take. Most of the patients outside of Egypt who have HCC are in sub-Saharan Africa. And this third bullet is really the worst bullet of the lecture, is that 95% of these individuals present with advanced terminal disease, where treatment is no longer, curative treatment is no longer an option. And again, that is totally unacceptable in this disease. Because if everyone in this world who had Hep B was being screened adequately, we would have very few patients. That would probably be about a number of 5 to 10%. Maybe a little bit higher, but I am very optimistic about the future. I do think that our technology is so wonderful that we will be coming up with screening techniques, blood tests, urine tests, imaging studies that will be so much better than what we have now. That I told you before, if we do everything right, 70% of patients are picked up with HCC at a curative stage. I think we'll be in the 90 to 95% area. So I want to reverse this number. In 10 years, before I hang up my shingle, I want this number to be about 5 or 10%, not only in the US, but also in Africa. And so as a result of that, only a very small percentage of patients are treated with an intent to cure. Most of the patients are just being treated to give them a little bit more time on Earth. We do have treatment options. One option is ablation, which has a 60% survival at 5 years, with a recurrence rate as high as 22%. When I see a patient with liver cancer, the first thing I think about is, how do I cure it? The best rates for cure are with resection and with liver transplant. So resection has a 50 to 70% survival at 5 years, but look at that recurrence rate, over 60%. I've been at Penn for 6 years. I've had 2 patients with liver cancer who were resected, and both of them had a recurrence within 2 years. One wound up getting a liver transplant, it's doing amazing. The other patient is waiting for a liver transplant, and she actually has undergone a TACE, which is at the bottom, while waiting for transplant. Liver transplant has a 70% survival at 5 years with a recurrence rate of 6 to 15%. If we could get rid of the organ shortage in this country and in the world, that would probably be about 80 to 90% survival at 5 years with a recurrence rate less than 5%. And usually if you don't recur within the first 5 years, your overall survival is excellent. TACE and TARE are other treatments. TACE is transarterial chemoembolization, and TARE is basically putting in radioactive beads into the tumor. These have a chance of cure with 30 to 40% survival at 5 years, but the recurrence rate is over 50%. So it's really not a curative procedure in most cases, but it holds people, it slows down the cancer while we're waiting for transplant. I have about 5 more slides, and then I'm going to open it up to questions. Again, this is a disheartening part of my presentation. Liver transplant is only available in 28% of North and South Africa, with 3% availability in East and West Africa. Central Africa has a very low rate of resection. Local treatment like TARE and TACE is available in 94% of the North and 72% of the South, but only 62% in Central Africa. And again, another upsetting comment is 16% of individuals who live in Africa have no access to any treatment whatsoever. Now, about 2 years ago, I was involved in a seminar, a lecture, a grand rounds on liver transplant in South America. And similar to this data, a significant number of people who live in South America have no access to treatment for liver cancer, have no access to treatment for liver transplant. And I just think that is just unacceptable. With everything that we have available to us, all the funds available, I mean, a liver transplant costs about $200,000, $250,000. I don't understand why we don't have organizations, charities that are able to set up situations where anyone in the world who needs a liver transplant can come to the US and get it done. Now, one of the issues is availability of organs. Obviously, that's an issue, but live donation is an incredible way for patients with liver cancer to get organs. And in fact, even in the US, when you have liver cancer, my number one recommendation is you need to find a live donor because you may not get a liver in time before that cancer spreads. So even for people with fantastic insurance who are in the US, if they don't get a live donor and they have liver cancer, they're putting themselves at risk. But again, if we have someone who comes from overseas who has a live donor, we should have something in place where we can do that. Again, I just think it's so unfair and unjust that individuals around the world do not have access to what I consider a miracle of modern medicine, liver transplantation. Egypt established a live donor liver transplant program about 20 years ago, now has 34 centers. South Africa has 2 transplant centers. I've always said never pronounce something when you're giving a lecture unless you know how to present it. But don't laugh at me, but Côte d'Ivoire has a live donor program with Egypt's help. And Sudan recently started a live donor liver transplant program as well. So there is encouragement that this is starting. But again, I get the sense, and you probably know better than I do, that many poor countries don't have the money to send someone to Sudan or Egypt to get their liver transplant. But again, when I retire, maybe I'll have time to help that, unless I win the lottery. Okay, next slide. What about systemic treatment of HCC? One of the things I really want to let you know is 40 years ago, there was nothing that was effective for slowing down liver cancer. It was basically a death sentence. Nowadays, we have over 10 different systemic treatments that we can give, along with the treatments that I talked about previously. The first 2 up there are checkpoint inhibitors, which are amazing advance, and probably about 10 to 15% of patients have incredible responses where the liver cancer just shrinks away. The second line therapy is sorafenib. That's an oral agent. The first 2 are not oral agents. So again, in Africa, the majority of patients are given sorafenib, which is not the best treatment. They should be getting first-line therapy, but these medications are so expensive. Only 11% of individuals in Africa have access to these checkpoint inhibitors, and only 42% have access to the second-line therapy. And you can see there, major gaps exist in access and availability of treatment in Central, Eastern, and Western Africa. And again, maybe all my really sad sentences are at the last bullet of each slide, but overall, only 3% of cancers are treated in Africa versus 76% in Egypt. In Africa, the rest of Africa, the median survival is 2.5 months. It's not much better in Egypt. It's close to 11 months. But again, these numbers really need to change, because with the right, well, if we set things up right, we can make liver cancer a curable disease. Obviously, it's not a curable disease in this part of the world. So future directions in liver cancer, I was really encouraged by this doctor from Egypt, and because I took this from him, but it's clear to me, I added 1 or 2 of my own, but he and I are thinking on the same page. We need to strengthen the national data systems and cancer registries. I'm actually doing a project with Blue Cross that got put on hold because of COVID. But the bottom line is, we should be able to go to Blue Cross, to go to Medicaid, and find out who in their system has cirrhosis, who has hepatitis B, and make sure they're being screened. I mean, that will be my job after I retire, if someone will hire me. And we need to set up a cancer registry. We need to screen with biomarkers. We have new biomarkers being studied all the time. I was actually involved in a research project about 10 years ago, looking for a urine test to screen for liver cancer. And this was very encouraging. It didn't work out, but it was very encouraging. But I envision a day where everybody all over the world, every 3 months, every 6 months, would do a urine dipstick that will tell them if there's any cancer anywhere in their body, because we know every cancer makes proteins and other biomarkers before we can even see them. So I think that's the wave of the future. Number 3, we need to eliminate viral hepatitis by 2030, which again will help lower the rates of liver cancer. We need to vaccinate everybody for hepatitis B at birth. There is no doubt in my mind that we could eradicate hepatitis B in 3 generations, make it like smallpox, if we could just go around the world and vaccinate everybody. We need to develop centers of excellence for treatment that everybody in the world can reach out to. So a couple of centers in South America, a couple of centers in Africa, a couple of centers around Asia. But again, we should be able to let patients come from all over the world, find a live donor, be treated. If they don't need a transplant, other treatments, and develop knowledge sharing virtual programs. That was his idea, but I added Project Echo. That's something we're doing with the Hepatitis B Foundation, where every month we talk about different hepatitis B situations, patients, different things. I spoke about screening for liver cancer. We screen for non-invasive ways to screen for fibrosis. So again, I think with technology, we should be able to share the message around the world without going all over the world about what needs to be done. Getting tired. I have 2 more slides. This is my slide. It's all me. Okay. So I usually talk about how to improve the hepatic health of the US, but since this is an international lecture, I put the world. So I may sound like a broken record, but this is important. We need to find and treat all hepatitis B and hepatitis C patients. We need to find and treat all patients with non-alcoholic fatty liver disease. I know they've changed the name, but to me, it will always be fatty liver disease. As someone who has fatty liver disease, I know it's because I'm fat. And if I could lose 30 pounds, I'd get rid of it, but that's easier said than done. But eventually, we will have treatments for these patients that will reverse fatty liver. And again, we need to screen these patients for liver cancer. Fatty liver, like hepatitis B, are 2 liver diseases where there's an increased risk of liver cancer, even if the patient doesn't have cirrhosis. Third bullet, we need to find and screen all cirrhotics and hepatitis B surface antigen positive patients for hepatoma. Fourth bullet, we need to find these hepatomas at an earlier stage with better screening modalities, whether it be radiologic imaging, blood tests, urine tests. We need to eliminate the organ shortage. There is no reason why there's an organ shortage in the world. I don't have time to go into that. But if we could transplant everybody who needed a transplant, and we should be able to, it would improve the hepatic health of the world. And the last thing is, it is important, this is a little bit of an aside, to make sure that you know the surgical risk of patients with liver disease, especially cirrhosis, using the vocal Penn calculation. And that's a calculation that my colleagues and I devised at Penn with the help of the VA to see how dangerous it is for a patient with cirrhosis to have surgery. And the last slide is the final slide of my career. That's the date of my retirement. That's November 13th, 2030. It is a little bit more than 7 years away. I'll be 70. And my goal is to be at that ocean park, that national park in the Virgin Islands on my 70th birthday when I retire. And I think I will leave it open to questions now. If you want to, you can leave that up on the screen if you want to, but I'll leave it up to you. Do you want me to stop sharing or what should I do?
Sure. If you want to stop sharing, and that's a beautiful picture, that would be great.
I will stop sharing.
Perfect. Thank you so much this is a really great and insightful presentation, and yeah, really covered a lot of grounds for what needs to happen, both in the US and internationally. So I'll start with one question from the audience. So yeah, so this is a big question, but so you spoke a lot about the organ shortage and the need to eliminate it. So so this individual asked, how do you eliminate the organ shortage? Don't organs come from other humans? So I know this is quite a large topic, but you had talked a lot about living donors, and maybe if you want to elaborate on how people who, it doesn't necessarily have to rely on people who've died, and expand on that a little bit.
Well, first of all, let me just say this. Even though living donor is necessary right now, I think it's unfortunate that we have to reach out to live donors. I mean, my estimate is over 1 million people a year die in the US, and yet we're doing 7,000 to 9,000 liver transplants a year. So that means that hundreds of thousands of livers are not being used. And I have a pretty radical idea that I think that we should allow a system in place where you can buy a liver, an organ. And again, I think it would have to do with a lot of oversight. There are places in the world where it's legal to sell a kidney. Most of the places it's not legal. But there was a study done a few years ago that the majority of US voters from both major parties felt it was reasonable and okay to sell an organ if done correctly. And I'll just give you an example. I know my dad, if he knew that I'd get $25,000 if he donated his kidneys and his liver, he probably would have done it. Because I think he would have wanted to leave me something. You could do it. You could donate to charity. Your favorite charity could get a donation. But there was a documentary. I don't remember if it was on HBO or not, but the people who made the documentary felt the same thing, that it should be with obviously, no coercion, whatever, but it should be something that should be available. You're allowed to altruistically donate a kidney if you want to, but if you want to get $20,000 for it, all of a sudden you can't do it. So it's a little controversial, but I think that's one way. The other thing is maybe technology will come up with a way to clone organs. That's also a possibility. But the bottom line is, it is clear that until that happens, live donation is a very good and very safe way to help eliminate the organ shortage.
Yeah, absolutely. And I see there was another question in the chat, which I think Kenneth answered, but yes, just so everyone is aware, the liver can regenerate itself. So you can donate a portion of the liver to another person, and then it can.
Let me just clarify that.
Mm-hmm.
When someone donates a third of their liver to another person, very quickly, both livers regenerate and they're normal sized liver. I think it's about 6 months to a year from where you'll have a normal sized liver. So yes, it can be done.
Awesome. Thank you so much. So another question, what is the average number of chronic hepatitis B patients who are functionally cured? And have there been any biopsies done in these patients?
Well, there may have been biopsies done in research projects, but it's not typical to do that. But it's a very small percentage. It's probably on the order of about 5 to 10% with the oral agents, maybe about 10 to 20% with interferons. But research is being done to make a functional cure. It's a little bit different than a real cure, like with hepatitis C, because there's always the possibility for reactivation with hepatitis B. But again, we do consider it a functional cure, and functional cures are associated with less progression to cirrhosis and less liver cancer.
Perfect. We have a question related to hepatitis C. So this is with the recent introduction of the cure for hepatitis C in the United States. Is this treatment available in Africa, to your knowledge? And if so, is there a way to treat more Africans? If you have any thoughts.
I'm not 100% sure about that. I do know that these companies that are making these medications have lowered their prices. Mm-hmm. And so, for instance, in Egypt, the cost is very low compared to the cost here. But my guess is it's probably not as available in other parts of Africa as it is in the US. And I think a significant number of people in Africa are not being treated, but I really don't have evidence or data to support that. It's just my general feel for the situation.
Okay, thank you so much. We have a question. Are there portable testing devices for screening for hepatitis B like we had for COVID?
Well, I don't think they're necessarily portable, but we do have ways to screen patients with not necessarily. You're talking about B or C?
I think B.
Yeah, I don't think there is something for B as of now. I think it's all blood tests, but I know for C they've come up with things that you can check with saliva and buccal smears and things like that. But it's not on the same scale as COVID. It's not even close.
I think there's an effort underway to have rapid tests for hepatitis B approved in the United States, but the FDA, it's currently extremely expensive to get to get the FDA to look at approving those types of rapid tests. So they're currently not available in the United States, but I think they are elsewhere in the world.
Okay.
Then we had some additional comments. So I think Kenneth had commented that more involvement of people with lived experiences and trained into becoming champions in the fight against liver cancer will have a great impact in addressing barriers to access to testing and linkage to care. So just do you have any thoughts on kind of how to involve? I know you spoke a lot about the efficacy of health navigators and how those can, help be helpful in making sure people attend their appointments and keep up with their care. Do you have any thoughts, either further thoughts on that or about the importance of involving folks with lived experience in addressing these barriers?
No, I think that's very helpful. But again, I do think that it's a very complicated process. You have to go out and find the patients. Once you find the patients, you have to make sure they have access to care and that they do follow up. It is clear. I mean, let me just say this, that I've been at Penn for 6 years, and I think at least once a year we have a patient from Africa with Hep B who either doesn't know they have Hep B or didn't tell anyone they had Hep B, and they present with terminal HCC. And one was actually a young teenager who was hoping to be a soccer player in college and actually presented with terminal HCC. He was signed by the local soccer team here, was a professional soccer player for a day before he passed away at the age of 19. But, we have to go out there, we have to engage individuals. And again, I think if somebody who's been through it comes with us, it will help. One of the things I'm trying to do right now with the Mayo Clinic is the Mayo Clinic with Lewis Roberts leading the charge is trying to publish data about the U.S. experience with hepatitis B in individuals from Africa. And I'm one of a few sites, and I have about 300 patients from Africa with hepatitis B. And it's just going to be a snapshot in time of where they are, what happened to them. And, my guess is we're going to see a significant number of patients with liver cancer and liver disease. But we have a lot of work to do. That's all I could say. And I would welcome working with anybody who wants to work with me. I will say this, that I'm allowed to do anything I want to help the community as long as I give my boss 6 weeks notice. So I can take a day off from seeing patients if you want me to come out there and help you screen patients.
Awesome. Yeah, well, you can share your email address if that's okay.
Please,
folks would be interested. Great. And I liked the ideas that you shared also about setting up a registry, working with African communities, both in the United States and in Africa to identify folks, working with insurance companies, primary care providers, and including as many different stakeholders and people who are part of the care cascade as possible. So I think that would be really beneficial. We have a question: how do you screen for liver cancer? Is it just an MRI, or if you could speak to the different sorts of processes? And I know you'd spoken about like potentially having a urine or blood test in the future. So if you could also just share how close those technologies might be, and if how much longer we might have to wait for those.
Well, those technologies are coming, but I can't tell you how far away they are. It's probably, my guess is 3 to 10 years away. But there are the one blood test that everybody does is the alpha fetoprotein. we're looking at other ways to do it. DCP, AFPL3 is another way to do it. The GLAD study looks at all three of those. Imaging should be done every 6 months. For me, if I had cirrhosis, I'd want an MRI every 6 months. MRIs and CAT scans are much better than ultrasounds, but the recommendation is ultrasound every 6 months. It's just too expensive to do CAT scans and MRIs every 6 months. There's actually a technique called shortened MRI, where instead of a 45-minute exam, it's a 15-minute exam that looks at the non-contrast and contrast phase. You can do it in 15 minutes. And if that works, it could be that you could do 3 or 4 MRIs an hour and maybe lower the cost. But imaging and blood tests every 6 months is the current standard of care. For me, I would do an MRI every 6 months if I could, but many insurance companies will not pay for an MRI every 6 months.
Absolutely. That's very promising. I think that sounds, because an MRI can also be a pretty invasive procedure. So that would be great to have a more rapid version. Mm-hmm. Another question. So if HCC is such a worldwide issue, why isn't it talked about more? Are we doing something wrong in raising awareness and education? Yeah, love to hear your thoughts on that.
So that was about hepatitis C?
That's about liver cancer, HCC.
Liver cancer? Well, yeah, I mean, I don't understand why. I mean, one of the things that I've wanted to do is get a celebrity of some sort. Mm-hmm. And I was thinking of, for instance, Joel Embiid, who's from Africa, or Jonathan Lind, who's from Asia, and have them talk about it. But we have not yet been able to do that, to get somebody to do it. But, you know, like I said, 70 people around the world will die while we've been on this lecture from liver cancer. So it is definitely something that people need to know about. But I'll tell you, in the US, we've been talking about it for 20 years, and we have been unable to make a dent in liver cancer. So that's why I think we have to think outside the box and just can't leave it up to the doctors, the nurses, the PAs, and the primary care doctors. We need to get another group to help us do this.
Absolutely. Yeah, I think having a celebrity presence is important, and just seeing what's been done around breast cancer, for example, in the US, and how, you know, that's pretty, has much more widespread awareness. So perhaps taking a leaf from their book. So we have a questions from Ibrahim Yarima, which is creating awareness on Hep B within our communities helps a lot. How can we test liver cancer or know someone is affected with liver cancer, and what is the cost for testing? So I think this is from the African context. So I know that there's an economic burden for sure, but if you have any thoughts on
well, first of all, I mean, you don't need to screen everybody for liver cancer. You need to find the individuals who are at risk for liver cancer. So that would be anybody who has hepatitis B surface antigen, anyone who has active hepatitis C, anyone with significant fatty liver disease. And those, definitely the cost is unclear in other parts of the world. I mean, I have to tell you, in Europe, it's $40 to do an ultrasound. Here, it's $1,000 to do an ultrasound. I don't think we pay $1,000 to do an ultrasound. You know, maybe we have $100 copay, but you know, prices are different all over the world. And again, I do think that it may be prohibitive currently to screen everybody unless you have funding to do it from different organizations. The sense I get from the lecture I just gave is that there is not a lot of money in Africa to take care of patients. I mean, so I don't know the exact cost off the top of my head.
Yeah, absolutely. And I know just to that point, Kenneth had mentioned just in a comment that most of African countries don't have the capacity to do the specialized tests to catch liver cancer early. And this is a huge challenge that has made it difficult for patients in poor economies. So I think that's definitely, you know, it's absolutely true and a huge issue that we have to work to overcome. So we have another question. So for individuals who are co-infected with hepatitis B and C, how likely is it that they survive liver cancer, or perhaps that they will develop liver cancer?
Well, they definitely are at a slightly higher risk for liver cancer, but they can do just as well as patients who are not infected. And again, hepatitis C is curative. Hepatitis B can be controlled. Usually, when you have two viruses together, one predominates. So in my career, the majority of people have one or the other virus that's predominant. And the only caveat is if Hep C is predominant, you do need to have people on treatment for Hep B when you treat the Hep C, because there can be flares of Hep B. But like I said, when you have two liver diseases together, you're more at risk for progressing to cirrhosis and getting liver cancer.
Absolutely. Well, thank you so much. I know we're coming up close to the top of the hour. I was just wondering, one final question. You had mentioned that you were in contact with pharmacies to encourage screening for Hep B in that setting. Have you found them to be pretty receptive to doing that and to?
It's funny that you asked that, because the first pharmacy I called was anything but receptive and considered me to be a royal pain for even bringing it up.
Oh no.
But I went online and I saw that there were a couple of pharmacies near me that would screen for hepatitis B.
Okay.
So I made a phone call, and the person on the other end was not very happy with me and thought I was a distraction. So I think I'm going to have to go somewhere else and figure out how to do this. But again, people go to the pharmacy, it seems, all the time.
Mhm.
People are in there once every month or two, once every 2 months. If there was an ability to just get screened on the way to get your medications, I think we could screen a lot of people. My other thoughts were going to sporting events, concerts, and having screening on site right there. But it's going to take a lot of time and effort and coordination. But
Yeah,
what we're
absolutely.
doing now is not working. It's just not working. We need to think outside the box.
Yeah, absolutely. Yeah, I think we have seen that people do seem to utilize pharmacies a lot as they're, at least in the U.S., as a more frequently than doctors' offices. So continuing to try that is a good initiative, and certainly, unconventional means of meeting people where they are. I know we have a lot of community organizations who have joined today who do a lot of efforts to hold events and include hepatitis B screening in those. So thank you so much. This has been a really insightful webinar. Thank you so much for everyone for attending and your really interesting and important questions. I think we have a lot of good takeaways from this. So again, we'll send out the recording and Dr. Rothstein's slides, if that's okay. And some of the top takeaways that we can potentially
Can I ask one more thing?
Yeah, of course.
Can you give everyone my email address at Penn in case we didn't answer all their questions, or if they come up with another question?
Yes, absolutely. I will send that out with the notes, and I can put it in the chat right now, actually. Can you remind me of what it is really quick?
It's Kenneth.Rothstein at Penn Medicine UPenn.edu.
Okay.
And again, it's the same thing I'll ask my patients. Give me 1 week to get back to you.
Okay. All right, fair warning. That sounds good. All right, so the email is in the chat. I will also share it with in the notes when we send out the recording and the other information. So again, thank you so much to everyone for joining today, and of course to Dr. Rothstein for this great presentation. We hope that everyone found it informative and valuable to your work or life, and that you can apply this information in some way moving forward, and we can work together to hopefully implement some of these innovative solutions. So again, the recording and slides will be emailed out along with Dr. Rothstein's email address. We also encourage you, if you're not familiar with CHIPO or our organization, to visit our website on the slide And if you're interested in CHIPO further, you can feel free to reach out to me for more information or to join our upcoming meetings. And we encourage you to follow us on social media. These links and email addresses will also be sent out to all registrants. So thank you so much again, everyone, for joining. And thank you, Dr. Rothstein, and we hope you have a wonderful rest of the day.
All right. Thank you very much. Take care, everyone.
Thank you so much. Take care.
All right. Bye-bye.
Bye.